But what I'm going to talk about today is something that I'm going to try to persuade you that Dr. Morrison is actually not exactly correct. This is my effort here today is to try to persuade you that what I'm going to talk about today is not so different from what everybody else is talking about. But you think it is, and that is I'm going to talk about depression and how depression ultimately is no different in many ways than the other aspects of these autoimmune diseases. It is caused by the inflammation that affects the brain, and that it is a treatable consequence of MS and transverse myelitis. We'll show you is that there was a study that was done out of UCSF. And it basically took a look at patients with multiple sclerosis. And what I will tell you is that the story with MS is the story with transverse myelitis. So I'm going to talk about them interchangeably, but I will give you evidence why this is a similar story between the two as we go along. But just for now, suffice it to say that I'm going to start off by talking about MS because that's the area in which we have the data to support the assertions that I'm making. And then I'll show you some of the data we've collected at the Transverse Myelitis Center at Hopkins to support that. But basically, this is a study that was done, a phone interview that looked at the psychosocial functioning of people on average about a decade after the diagnosis of multiple sclerosis. And the interesting thing about this was that they then took the answers that these individuals gave, again, about a decade after the diagnosis of MS, and they categorized their responses into three categories. The first was that that many patients endorsed that their MS had somehow led to a deterioration in their relationships. It had caused a stress for them and their caregivers and the like. And that was about 20% of people endorsed that, meaning 1 in 5 people said, yes, the MS had caused a strain on my relationships with my friends and family and loved ones. And I don't think that's a shock for anybody in the room to hear that if you have a chronic illness like MS, it can do that. 30%, 1 in 3, said that it led to demoralization, and here by which they meant that it had sort of overwhelmed their coping strategies. People were despairing at times. And I will tell you again, since the cross-sectional rate of depression is 25% in MS, meaning at any given time 1 in 4 people with MS is suffering from a clinical depression, probably that 30% is significantly made up of people who were suffering from depression at that time. But the take-home message from this slide is actually that this 60% were people who endorsed what they categorized, for lack of a better term, as benefit finding. Now, what does that mean? That means 60% of people 10 years into the diagnosis of MS said that in some ways MS had actually given some benefit to them, had somehow enhanced their life. And I'll give you an example. Next slide. So I'm supposed to be able to do this myself. Okay, great. So let me just give you, when you hear that, you think, well, what am I talking about? And these are actually what people endorse. So my friends and family had become more helpful. I am closer to my family. I am closer to my significant other. I keep in better touch with my family. And I will tell you the number of patients I've had who describe that they were going along their life, working from morning to night, coming home. And now with the MS, they're actually spending more time at home with their family, working less to the grindstone, appreciating life more. They've learned to be more compassionate, more respectful of others, express their feelings, communicate better, be a better friend, appreciate life more. And again, my friends and colleagues and patients who require assistance with ambulation often tell me that walking is wasted on the ambulatory, that you don't really appreciate what it's like to walk until you lose that ability. But again, the reason why I show you this is that all of us who have worked in this area have continued to be amazed by people who continue to teach us that the hurdles that are placed in front of us needn't be necessarily a negative thing. And you just take a look at Cody, for example, what she has done with the hurdles placed in front of her, sort of has gone on with her mom and family to create, the Cody Answer First Step Foundation that has led us all to get together. So it's not an inevitability that just because you would have an illness like multiple sclerosis or transverse myelitis, that would mean necessarily your life is over and there's no reason for hope or the like. And in fact, the majority of people in the studies that have been done, argue against that. They say in some ways, not only is this not the end of the rope, that end of the line, that in some ways their life has been enhanced. So, and again, this is a quote from Cody. Oops, except we got a little bit ahead of ourselves. So if you can't be normal, be spectacular. And again, I think Cody exemplifies this and lives this. And this is a quote she gave at a conference that we had in Maryland a little while ago. But again, George Eliot, a writer of the 19th century, said, "There is no despair so absolute as that which comes to the first moments of our first great sorrow when we have not yet known what it is to have suffered and be healed, to have despaired and have recovered hope." And again, that study that looked at people with MS was 10 years out. So oftentimes acutely, and sometimes in the first couple of years or few years, it's not uncommon for people to be suffering from the difficulties of adjusting to life under altered circumstances. And again, hopefully those people who are affected or those families who are affected by transverse myelitis and multiple sclerosis and other related autoimmune diseases have not had lightning strike multiple times. So this is the first big challenge, the first great sorrow. But again, when you sort of look at this sorrow and this despair, the question is this demoralization or is this depression? So from a clinician standpoint, if someone comes in and they are unable to sort of get on with it, unable to find purpose, unable to sort of regain the sense of direction and purpose that they had in life, the question is, what are you dealing with here? Are you dealing with someone who is demoralized or depressed? So we're sort of going through the differential of someone coming in despair to the clinic. And first you have to understand, before we get to depression, what demoralization is. Demoralization is a state of helplessness, hopelessness, confusion, a sense of incompetence, a subjective sense, isolation, and diminished self-esteem, which is a long-winded way of saying that those people, all of us have some point at which our coping strategies would become overwhelmed, and we sort of shut down and say, I just can't cope with what I now have in front of me, and I can't get out of this situation. I'm sort of trapped. And when stuck into that situation, what the subjective experience is to be the failure to meet expectations. Usually people feel like I just am not living up to my own expectations. I'm not doing the things I really should be able to. I should be able to just shake this off and get on with it. But also the feeling of being overmastered by the situation and isolated. And that feeling of isolation is often what is very isolating unto itself, because people think, I just, no one understands, no one else is going through what I'm going through. So a lot of times coming to this conference and these kinds of conferences and sharing with other people your experiences, you realize you're not alone. And again, this demoralization is something that not only affects patients, but it affects their loved ones. And one of the big unmet needs in this entire area of care is the caregivers. And so when I go to conferences, so let me just, as Dr. Greenberg did before, sort of go through, it's voluntary of course, but let me ask a raise of hands for those people who are here. How many people are here who are personally affected themselves as patients with multiple sclerosis or transverse myelitis or related illness, okay? Great. And how many people here are the family members or loved ones of people who are here, okay? So it's sort of the other half. And how many people who are the family members have ever been to an appointment with your loved ones when they go to a neurology appointment or physiatry appointment and the like? So that's pretty much everybody raises their hand. And of those people who are the family members, how many people have ever been taken aside by the neurologist or urologist and asked how you're doing and how's it going and how things are? And people laugh, and I just think that's interesting, and there are no hands that went up. And I would say that that's a real problem, okay? And the reason why that's a real problem is because it is hard to personally have one of these illnesses. But the idea of having one of these illnesses and going it alone, sort of being up a creek and now losing all your paddles, is a devastating consequence of sometimes the isolation that can take place. And so really, it is one of the unmet needs is that physicians really don't spend enough time shoring up the support network. So you want to make sure that your patients have adequate resources. Do they have assistive devices? If you need a wheelchair, do you have a wheelchair? But also, if you need a family member who's going to be able to help you, do you have a family member? When people come in to see me, often one of the things I have to do is try to convince not only the patient but the caregivers that the health of the caregiver is absolutely crucial. And one of the most important things that I have to convince the caregivers is this. is that, when you're flying in the airplane and the flight attendant comes up and says, to those people who shouldn't be given, sharp objects, how to do the seatbelt, and then they go on to explain that parents traveling with small children, if the oxygen mask dropped down and in the event of loss of cabin pressure, which is a nice way of saying that the window blows out and suddenly all the oxygen rushes out of the plane, you should put the mask on who first, yourself or the children? Right. And there's someone who's adamant about that, yourself, and that's really important. But the people who are always in trouble when they come in to see me are the people who will say, well, of course you put it on your children first. And that's what they keep doing. They keep trying to put it on their loved ones first. And the problem with that is you have about 20, maybe 30 seconds once the oxygen gets sucked out of that airplane before you lose consciousness. And if you're spending that time fighting with your children, they're going to pass out and you're going to pass out and no one makes it. If, on the other hand, the oxygen gets sucked out and you put the mask on yourself and you sort of try to get it on them and watch the clock, and then they pass out fine, you put the oxygen mask, everybody does well, okay? But the point is that you have to make sure you take care of yourself if you're going to be of any use to anybody else. And so once I explain this to people, then I ask the caregivers, the loved ones, I say, are you getting enough oxygen? And they say, well, sort of, kind of. And I say, well, are you still maintaining the friendships that you had before the diagnosis? They say, oh, I have no time because I'm spending all my time. Well, are you still going to the movies yourself or going out to coffee houses? Are you doing the things that you need to do to recharge your engines? They say, oh, I couldn't possibly do that because I can't leave my loved one at home. And the problem with that is if you don't do that, then you're going to ultimately end up burning yourself out. And so taking care of yourself is not something time away from your loved one whose body has been the one affected. It is something that you do for your loved one. So for those patients who are here, you must push your loved one out of the house and tell them, please, go see a movie, go get in touch with your friend, so that when you come back to me, you're going to be less irritable and more happy for all the requests that I'm going to make of you in terms of continuing to help out. But again, make sure you get enough oxygen and make sure your loved one is getting enough oxygen. So that's demoralization. Now, what is NDD? That is major depressive disorder. That is not man in a deep depression. But William Styron says he hates the term depression because depression is often used for a downturn in the stock market or a divot in the road, and that doesn't describe the illness that almost killed him, right? And so what he likes better is what Hippocrates, the father of modern medicine, 2,600 years ago, Hippocrates was the first one to describe what we now call major depressive disorder or clinical depression, and he called it melancholia. And he described it as a state of aversion to food and helplessness and a sense of hopelessness and despair, and sort of the same kinds of things that we do today. Interestingly, he said it was due to bile getting into the brain. Melancholia is, cholia comes from the same place as cholecystectomy, the gallbladder, and the belief was that this bile from the gallbladder got into the brain and affected the mood through its effects on the brain, causing this thing called melancholia. And if you substitute for this idea bile things like serotonin and norepinephrine, you actually have a fairly modern explanation of what we call depression, some chemical change in the brain. But it was unfortunately Freud in the last century that said, the reason why you're depressed is because your superego's on one shoulder and your id's on the other shoulder telling you to not sleep with your parent of the opposite sex or sleep with your parent of the opposite sex. And that makes no sense to me whatsoever. So I think going back now 2,600 years to where Hippocrates started off is really a much better place to start. So what I need to now convince you is that depression is not what you think it is. And now I'm talking about clinical depression, not that divot in the road. So to begin with, if you've never had depression treated, then you really have to forget everything you know about it. And let me give you, just take you through some of the common misconceptions. First of all, there is a thermostat in the brain that gets stuck. Just like if the thermostat in this room gets stuck and it gets colder and colder and colder, nothing will turn it up, or in this case, perhaps hotter and hotter and hotter, depending on the time of the day. But again, it's this unresponsiveness of the mood that is the essential part. And if you don't believe me, by the way, there are lots of examples, such as cocaine, which exploits this thermostat. And people who are addicted to cocaine have no physical kind of withdrawal syndrome like you do with heroin or alcohol. They just can't give up that sense of that euphoria that they get because it turns their thermostat, their mood thermostat, way up. Similarly, we now have stimulators that people are using for Parkinson's disease, where you, in severe cases, we actually put an electrical stimulator, an electrode into the brain and stimulate the region that actually will interrupt that the part that causes the shaking of the of the brain, of the substantia nigra in the brain. And there have been some cases where that electrode has been misplaced, and when they turned it on, people began to cry instantly and had the sense of this dark cloud circling over their head and utter despair, and said, and when they stopped the button and stopped the electrical stimulation, they suddenly emerged back into their normal mood, and they said, whatever you do, don't hit that button again. So we know that there is a part of the brain that regulates the mood, and that it controls this aspect. But again, there is an underappreciation of the role of biology playing a role here, and it's just sort of ironic because when people have MS and transverse myelitis, a lot of times it took effort to convince the doctors that, look, this isn't all in my head. People get sent home from the emergency room saying, you're just stressed, that's why you're not walking or peeing, which of course makes no sense. But unfortunately at the time, that's what often happens. But now my job is to convince people that just as they were right, that this wasn't just all in their head, that they really had something, and once they did the MRI of the spine or brain, the doctor saw that. Now what I'm trying to convince patients is that this depression also isn't just all in your head, that this also has a biological basis. And again, the second common myth is that depression is just a state of mind, a weakness, or a character flaw, and this is what gets in the way of people from getting the help that they need. But I can tell you there is a genetics to depression, which is the same heritability as high cholesterol. Everybody knows cholesterol runs in family, high cholesterol. It also is something that we can measure the architecture of people's sleep. When you go to sleep, there's a rate at which you go into rapid eye movement sleep, and that's different. The sleep architecture is changed in people who have depression. We can also measure blood changes in people who are depressed. There's something called the dexamethasone suppression test, which shows that people who are depressed make too much stress hormone called cortisol, and it's about 80% of people who are depressed overproduce this cortisol. So there are biological changes that we can measure. We don't use this very often because 80% isn't great. That means 20% of the time you'll miss somebody with depression just because they have a negative test. So and it involves coming into the hospital and overnight sort of getting dexamethasone and measuring it in the morning. It's a bit cumbersome. But we need better biological markers. But in any case, there are biological markers that exist. And again, what I think is very convincing ultimately that depression is not just a state of mind or a weakness is that lots of medical illnesses cause it. And this is just a list. Basically, anything that affects the brain can cause depression. Stroke was the first one ever to be shown to cause depression. That was in the 70s. It was only the 70s that we actually first had the idea that something in the brain, like a stroke, could cause a depression. But really, the gold medal winner, the Michael Phelps of causing depression or multiple sclerosis and transverse myelitis, they cause depression at a higher rate than any medical, neurological, or surgical illness. So these are the record holders, okay? These are the number one causes, or they are the number one in terms of their ability to cause depression. And again, lots of people ask me how I ever got into studying this, and I sort of ask them, well, do you know why Willie Sutton robs banks? Because that's where the money is, and so why does Adam Kaplin study MS and transverse myelitis? And one of the answers is because that's where the depression is. Another answer is because that's where Chitra Krishnan and Doug Kerr are as well, and they sort of said, look, we want you to come over and work on this area with us, and I came. Okay, another myth. Depression is not a serious problem. Okay? And this I hear from physicians, look, it's not my thing, it's your thing, you're the psychiatrist, you take care of it. It's not my thing, I'm the cardiologist, I just worry about the body. It's not a big deal, let them just suck it up and get on with it. But again, what the former Surgeon General Satcher said is far more, what many Americans don't realize is that far more Americans die from suicide than from homicide. So it's a dangerous world we live in, but for every 2 homicides you read about in the paper, there are 3 suicides. It's 50% more common that someone will kill themselves than kill somebody else. Virginia Tech aside, by the way, just so you know, there are, on average, there have been something on the order of 50 homicides that have taken place of college students killing other college students on campus. And that's in contrast to 1,100 suicides on college campuses every year. Okay? So it far outweighs the sort of aberration of what you see at Virginia Tech. Also, depression turns out to be the single best predictor of cardiac mortality after a heart attack. So in other words, if someone has a heart attack and they are depressed for the next 12 months, during that time period, their rate of dying from sudden cardiac death is higher if they are depressed than if they smoke, than if they have high cholesterol, than even if they had another heart attack or how bad that heart attack was. Turns out it's the single best predictor because depression, it turns out, is not only not good for the brain, it's not good for the heart as well. So it's not an inconsequential effect. It is a major one. And it is a leading cause of disability worldwide. In fact, it is the second leading cause of disability in the primary care setting. So when compared to diabetes or hypertension and rheumatoid arthritis, depression is second only to cardiac disease in terms of the level of disability it causes, number of days spent in bed and difficulty going to work and the like. It has a devastating impact. And to just say it's not my problem or not a serious problem forgets the fact that it is a major cause of morbidity and mortality. Let's see if we can get this. And again, for those physicians in the audience, you don't want to end up in this situation. I can't understand a word you're saying, Roger, if you've got a gun in your mouth, okay? So what this reminds me to tell people is that, yes, people kill people, but when they kill people with guns, there's a little teeny margin for error. So if someone is depressed, you got to get those guns out of the house. And women are 3 times more likely to attempt suicide in our society, and men are 3 times more likely to succeed because women do what? They take pills, and then they go to the hospital and get charcoaled, and then men try to shoot themselves. And that margin of error with a gun is so infinitesimally small that guns are really important to get out of the way. So again, this is what I hear all the time as the fourth myth that are used to dismiss the diagnosis of depression, which is, look, the patients are depressed, but you'd be depressed too if you had MS or if you had transverse myelitis. And once you say, but look, actually, they're depressed in a way, and you show them how depressed they are, say, yeah, okay, they are depressed, but that's just to be expected because of their situation. And again, for anybody who's read Tuesdays with Maury and understands something about Lou Gehrig's disease, ALS, where from diagnosis to death is normally about 6 to 12 months, and you die on a respirator, unable to move any part of your body except maybe your blink and the like, a horrible diagnosis. And yet, because ALS doesn't affect the brain, it affects the nerves that go and innervate the muscles of the body, it turns out that depression is quite uncommon or even rare in patients with ALS right up until the time that they die on a respirator. It doesn't mean they don't get demoralized, but they don't get that constellation of symptoms that we call clinical depression. So what is depression again? It is just to differentiate it. It is not normal sadness. It is not demoralization. What normal sadness is a universal response. We all are, and it happens intermittently when we are overwhelmed. It is all, unless you're depressed, unless you're sad at some point during the course of your life, you're not paying attention to what's going on around you in this world. So it's to be expected. But really what we're talking about here is with depression, we're talking about something where sadness is just one possible symptom. Let me see if I have, yeah. So for instance, sadness is to major depression what cough is to pneumonia. So for example, lots of people have cough that can be an indicator of pneumonia, but someone will cough during the course of this talk, and it won't necessarily, hopefully, be, in all likelihood, it won't be from pneumonia. It'll be from dry air or choking on the water or asthma or what have you. And in fact, not every cough is a result of pneumonia. Sometimes pneumonia presents even without a cough. So what you really need to consider is the cough is just one symptom. What company does the cough keep? If it's a productive cough associated with rapid breathing and a fever and then a white fuzzy region of consolidation on a chest x-ray, we call that pneumonia. What do we call depression? Well, again, that sadness is one of 9 symptoms that you have to have. I think I'm wearing this poor pointer out. So sadness is one of the symptoms, okay, but there are 9 symptoms, and they consist of decreased or increased sleep. Normally, by the way, that decreased sleep involves waking up early in the morning and unable to fall back asleep, what's called early morning awakening. Loss of interest or pleasure, things that used to be enjoyable no longer are. People describe their get up and go has gotten up and gone. And that feeling of guilt or worthlessness, that low sense of self-esteem, I'm just a burden to people. I don't want to go in and see the doctor because I'm just going to burden them. I don't want them to take any time and worry about me. The sense of fatigue or low energy, low mood, again, one of the symptoms. Concentration problems, and the concentration problems with depression can be so severe that it actually looks like dementia. I've seen patients myself in nursing homes that were misdiagnosed as Alzheimer's disease. You treat the depression and they go home and live independently for years to come. and it's either a decreased or increased appetite. Women often describe chocolate as the thing, the sort of comfort feeding, or it can be a tremendous sense of weight loss, or tremendous weight loss with loss of appetite. And then what's called psychomotor retardation usually, which is people feel like they're slowed down. You can just look at them and they just look sad and depressed and like they're moving through molasses. And then thoughts of death. So you need 5 of those 9 symptoms to make the diagnosis. Really, these are clinical symptoms. So just like Doug and Ben went through the symptoms of transverse myelitis and the pinprick and everything, not everybody's going to say, oh, just because you heard how to do the pinprick assessment, that you can establish the sensory level and go out and diagnose transverse myelitis on your own. A trained mental health professional should be the one to ultimately tell you whether these symptoms are the characteristic symptoms of depression. But if you find yourself or your loved ones having this constellation of symptoms, then it should raise the red flag, could this be depression? And this is after many years of marital bliss, tension enters the Kent household, and here Lois Lane is embroidering stupid on the cape. And what I can't tell you is whether Lois Lane is depressed and her Superman isn't so super anymore, or whether Clark Kent is depressed and not getting up and putting on his cape and going to save everybody. But I can tell the clinicians in the room that if you know your patient and you've seen them over years, you know when they're depressed. And if there's one question that you should ask yourself, is this the person who came into your office on the first occasion? But if you don't know that person or you're not sure, ask their loved one, because that's the person who probably sent them in to see you, saying, honey, you got to go see the doctor because something is really wrong, and either you go see him or I'm going to drag you in myself. So usually it's the loved one who encourages the person to come in to see the clinician. And if you just ask that person, who's usually in the waiting room at home waiting to hear what the doctor has to say, then you can find out. And if there's one question I ask is this the person you married? Okay? And they say, no, this is not that person. They have changed. They are no longer interested in doing the things they used to be interested. They've lost all their energy. They're just irritable. They're not the same person. So now let me talk to you about depression and MS, what we know. Again, this just shows the common presentations. I think I'm not going to go through what MS is, but MS, again, because it can affect any region of the brain, can cause any set of a multitude of symptoms, from loss of sensation in the legs, optic neuritis, visual loss, double vision, etc. And this is actually Charcot, who was the first person, the father of MS, the first person to describe multiple sclerosis at the Salpêtrière in Paris in 1868. He gave a series of lectures that we still understand are the gold standard for the diagnosis of MS clinically. And interestingly, the very index patient, the very first patient ever described who had multiple sclerosis, which was termed disseminated sclerosis back in the day, was actually someone, this Mademoiselle V, who was a 31-year-old woman who had such a serious depression that she became paranoid that Charcot was trying to poison her, and she stopped eating and needed a stomach pump to keep her alive. So right from the very start, we sort of had an inkling that maybe depression was involved in this illness. The index patient almost died from the depression that accompanied her MS. But again, as I told you, the lifetime prevalence of depression in MS is generally about 50%. So that's 1 in 2 people following the diagnosis of MS will get depressed. And as I said, that's 25% in cross-section, meaning at any given time, 1 in 4 people are depressed. Now, depression is common in MS, and it's associated with significant morbidity and mortality. But I'm not going to have time to go into all the details, but let me just tell you that it is not, gee, you'd be depressed too if you had MS, in part because of that study I showed you 10 years out. People, the majority of people are not only not depressed, they've found benefit from their MS. But again, more importantly, I think, to convince you is the fact that it's no correlation with physical disability. It doesn't matter if you're in a wheelchair or not. That doesn't correlate with whether you're depressed. So again, if it was, gee, you'd be depressed too if you had MS, it should necessarily be worse if you're in a wheelchair, or necessarily be worse if you have, bowel or bladder problems, or the worse your physical symptoms, and that's not the case. What it does correlate with is the periods of immune activation. When the immune system gets activated and starts attacking the brain, that's when people get depressed. That's when they try to kill themselves. And the work I'm doing in Doug Kerr's lab is looking at the way this inflammation actually changes regions of the brain and blocks the ability of the brain to produce new neurons. And I'm happy to talk with people about this at some other point. I'm not getting into the biology of depression here. I think it's more important to understand the clinical aspects. But we're starting to understand better how the inflammation affects the brain and how we might be able to, through understanding that, diagnose and treat it better. But again, let me just tell you, the impact of depression in MS is devastating. In fact, depression is the #1 correlate of quality of life in people with MS. In other words, if you ask people what seems to correlate best with whether their quality of life is good with MS, if you have depression, it trumps everything else. Doesn't matter if you have family support or if you're ambulatory, what have you. If you're depressed, that's the worst possible outcome for your quality of life. Secondly, it affects people's function. And in fact, when you look at what affects people's relationship to their loved ones, those people who are depressed have the worst impact on their relationships with their loved ones. So again, if you don't think getting your depression is worth treating for yourself, you need to treat it for your loved ones. So I'm going to go into a little bit hyper gear here because I'm getting the cane is coming to yank me off the stage pretty soon. So, right. It also turns out that when you're depressed, it affects your cognition. So those people with MS, as you heard earlier today from Dr. Ford, I believe, that depression, that MS can affect people's cognition, but it also, depression can affect people's cognition, and it amplifies any effects that the MS has. Fatigue, turns out fatigue is bad, but fatigue is made infinitely worse. And if those people who have fatigue that is unrelenting all the time, 80 to 90% of those people who have that unrelenting fatigue with MS, turns out that the depression is driving most of it. And you treat the depression, and that fatigue may go from 80% severe to maybe 20% or 10% severe, and it makes a huge difference. And then with respect to longevity, this just shows you the three most common causes of death in MS. Pneumonia is the first, cancer is the second, suicide's the third. It's the third most common cause of death across the entire lifespan. And again, 30% lifetime incidence of thoughts of wanting to kill yourself with MS, 6 to 12% of patients attempt suicide, and it's the third leading cause of death. So to dismiss depression is missing the one thing that can really end your life sooner rather than later. So I'm just going to, unfortunately, have to go through this rather quickly, which is transverse myelitis, just to convince you here. What this shows you here is that transverse myelitis, again, I told you MS, highest rates of depression that have been described to date. Well, it turns out TM here, you look at the blue and the red bars, and that shows you severe and all forms of depression. And you can see that in TM, the severe depression, 16% compared to 8% in MS. This is the data we collected in our clinic. In fact, severe depression in transverse myelitis is at least as common, if not more common, than in MS. And this just shows you the purple bars. You just have to take my word for it, that the purple bars show that the cognitive impairment you see in MS is exactly the same pattern. See, these purple bars are the same pattern and the same heights in TM and MS. You get the same kind of brain involvement in TM, even though it's not obvious. This just shows that the depression in TM doesn't correlate with sexual function, bladder dysfunction, whether you're in a wheelchair or not. There was some minor correlation with sensory disability, but I can't tell you if that's those people with pain, neuropathic pain in TM, were more likely to endorse being depressed, or whether the depression actually caused, or whether the neuropathic pain caused depression, or whether the depression made people more sensitive to the effects. But I can tell you that it doesn't correlate so much with the disability as it does with the inflammation. And this shows you, unfortunately, this is the rate of suicide in the general population, 12 out of 100,000. This is in major depression. This is the rate of suicide in multiple sclerosis, 168 out of 100,000. This is the rate of suicide in the Transverse Myelitis Center at Johns Hopkins. You can see it is 60% of all the deaths we've had to date in the Transverse Myelitis Center have been due to suicide. And again, this is the most treatable aspect of this illness. Hard to get people up and walking again, but not so hard to get them treated. Yeah?
That was before I joined.
I'm sorry. So Ben, I should tell you, is a human antidepressant. He can lift people's spirits just by spending time in the room with him. But in any case, we unfortunately in that high size study that Doug was showing you earlier, we had a patient who shut down his inflammation with the high-dose cyclophosphamide. He did great for 18 months, and unfortunately his MS started to get reactivated, and we knew that because of two things. One was that he had new lesion on his MRI that he had not had previously, and the second way we knew it is that 2 weeks ago he tried to commit suicide. So that was the earliest manifestation of the return of his MS. Had been doing great. His depression that he had had previously was doing so much better. He was getting going, had gotten a job, was really getting going in his life. But the onset of the activity of his MS was heralded by his suicide attempt. So again, I'm just going to summarize this by telling you that depression, it turns out, worsens MS. Those people who are depressed have more exacerbations and more lesions in their brain. This study actually showed biologically that those people who have MS and are depressed, their immune system's twice as aggressive. It is making these interferon gamma and these biomarkers of angry MS, twice as high as those people who are not depressed. And when they treated the depression in those patients with MS, their immune systems calmed back down to control levels. This is, of course, your daddy loves you. He's on Prozac. He loves everybody. And the most important take-home message, if there is one, is don't forget about depression in these illnesses. Don't forget that it is caused by the inflammation affecting the brain. It's not a personal weakness. But also don't forget that it is treatable. And again, I'm going to just suffice it to say that when the U.S. Air Force decided to treat depression, what they found out here was they put together a program across the U.S. Air Force in the late 1990s, and they went from 10 out of 100,000 U.S. Air Force personnel committing suicide to 1 out of 100,000. They had a 90% reduction in the suicide rate in the Air Force when they addressed the issue of suicide and depression. So again, take-home message, remember depression and MS as well as TM is a two-way street. MS causes depression, depression worsens MS. Treating the depression probably improves the MS. I just told you about that data. But as well, treating the MS improves the depression. So don't forget it's a lethal consequence. Khalil Gibran said the deeper sorrow carves into you, the more joy you can hold. This is Paula Lazari. This is Paula who got transverse myelitis at the age of 12, right, Paula? 12? Yeah. And she's here. She tried very hard and trained for a while. She'll tell you all about it. To walk across the stage here, which people told her she couldn't do to get her diploma in high school. She was told she couldn't have kids, and Ben will tell you how, and Donna will tell you how that is actually absolutely false. But back at the time, she was told she couldn't. And here's her son Jesse, a strapping young man who's actually even taller and more strapping. And here's what Paula says. And this is what you can do when you're not depressed, right? You can say things like this. My life is good because I will have it no other way. My life is beautiful because I choose to see it this way. We cannot control what happens to our bodies. We cannot control what goes on in the world around us, but we do control how we think and feel about ourselves and our families and the world we live in. And it's all good. Life is very, very good. And if you don't feel this way, talk to Paula because she's an inspiration. And if that doesn't do it, then come and talk to me because then we need to see if there's something else intervening. And again, I'd like to thank Doug and Chitra, without whom I would not have even been in this area of work. And of course, Cody Unster and the TMA and all of the people who have taught me. Patients are the ones who really taught me about depression, Ben and Peter, and everybody else who was involved in the research. And sorry, I ran over a little bit, but I'm all done.